to our second meeting of our 2021 virtual Fabry community meeting series. We really appreciate everyone being here. We especially appreciate Dr. Victoria Lawson for providing a presentation on Fabry and pain this evening, or maybe this afternoon, depending on where you're sitting. But and we may have people from around the world also, so it could even be morning. But anyway, thank you, Dr. Lawson. Dawn is going to make a more formal introduction, Dr. Lawson, in a few minutes. And I'd like to talk about Dawn. So my co-host, Dawn Laney, most or all of you probably know. And if you don't, you've been missing out. So I'm going to pull up a screen, share a screen with you for a second. And oh, Brenda, could I have screen share back? Or could I have it? I don't have it. Brenda, can you hear me?
Okay, you should have it now.
Okay. All right, thank you. So I'm just going to show you our registration website for a second, and you've all seen it because you're here. But I just wanted to look at a couple of things. So on the on the registration website, as you probably know, we have speakers and bios. I want to point out two things while they're here. I'll get to the I'll do the minor one first. We added a tab on the far right on the top menu bar for archives and recordings, and you'll see that the recording from the last meeting on Fabry disease and the heart is already available and ready for you to view. And the next meeting, this meeting here, the recording will be available in a couple of days. And I see, yeah. So let me go back to the last screen. And speakers and bios. So there's a speakers and bios tab, which you may have already seen. And in that, it's alphabetical. So you scrolled on to Dawn. Dr. Lawson is right there also. And Dawn is going to introduce her in a moment. And Dawn's bio is right here. So you select the little tab on the, can you see the Zoom screen in the middle of that, or is that just me? You probably can't see it, right? Okay, so Dawn has done more things that we can talk about in this amount of time. And I'll just give you the brief. Dawn's from Emory, and she also provides a lot of support to the National Fabry Disease Foundation. But she's done so many things as a genetic counselor, assistant professor, a clinical researcher, the program leader of the LSD Center at Emory, and the director of the Genetic Clinical Trials Center at Emory also. In addition to many authors of publications or contributors to publications, and many other projects and programs that we don't have enough time to talk about. In addition, if you look on our website, you'll see all the kids' books she's written about Fabry disease in kids. So we really are thankful to have Dawn as my co-host and co-moderator with us. And I'm going to, before we give you to Dawn to introduce Dr. Lawson, I'm going to show you another slide, do a couple of announcements here. And let me find that if I can. So this is just a slide, two things. If you look back on the registration website that I was showing you a moment ago, you'll see on the far right, there's the sponsors tab. So if you look on that, you'll see all the sponsors that contribute to provide funding for us, to allow us to have programs like this. And along with that, we put a slide up just so part of our job is, I think you know, we put a lot of effort into keeping you informed about what's going on in the community with not only education initiatives, lots of other things, including what's going on with industry and clinical trials and what the different organizations are doing. So you'll see, and this will be in the recorded slide presentation that you receive also. You'll see where various companies, Sanofi Enzyme, for instance, have a couple of websites that they want everyone to know about. Amicus has the same, and Amicus just announced today, we posted the next meeting for a women's meeting for them on April 11th. So that information is there. Casey has their Rethink Fabry website that they'd like everyone to know about. AvroBio is still enrolling in their clinical trial, and you can see their website and get information there. Sangamo is also still enrolling in their clinical trial, and I'll hit 4DMT also. 4DMT is also enrolling in their clinical trial, and they've just dosed their first patient today. And then Idorsia, of course, have closed their trial. They've finished recruitment, and they're moving along toward all the things they have to do to request an approval of their substrate reduction therapy. So, I think as you probably feel the same way I do, that we have so many good things going on in the Fabry community, and some or all of these perhaps will lead to solutions that provide everyone with Fabry disease with a treatment that's best for them and that they're most interested in. So use this information to either contact your doctor or contact the organizations. And if a clinical trial sounds right for you, do it. It's how we got the where we're at today. I was in the Fabrazyme clinical trial since 2002, and we wouldn't be where we're at without people participating in clinical trials. So the next slide I have is, if I can get to it. I thought I was in slide presentation, but evidently not. I seem to have little bugs going on here today. Okay. This is a feature we added to our website not long ago, where if you look at the top menu bar of our website at www.fabrydisease.org, you go down to the last tab, and it says Company Info tab. You'll see pharma info, clinic info, and support organization info. And then you scroll into those, and you'll see each one has a read more button in their block under their logo, and it keeps you up to date with the resources that industry wants us to highlight. They think they're useful for you, and gives you the updated information on what each company is doing at the moment. And so it's a good way to kind of keep up with what companies are doing. They provide us news releases and information when we should add something to this. So it's a good feature for you to be able to keep up. You can also go into the support organization tab. Today, we just added a third tab here, the NFDF tabs. The last tab, the third one, contained all of our videos from our 2020 conference in October. The middle tab that we just added will also include the recordings that we're doing from this series. So you can visit that when you like. The next thing I have is our calendar. We have about 1,000 calendars to distribute. So we just want to make sure you all know that. If you're participating tonight, we'll send you a calendar once we compare your registration information with what's in our contact database and make sure if there's any imbalance there, make sure we're sending a calendar to the right place. So we'll contact you before we send it. And if you had a change that's not in your registration, make sure you send that to me. And my email is all over the place. It's on this slide also, so that we don't actually spend $20 sending you a calendar to somewhere that you don't live. So please help us with that. And if you're not already subscribed to our newsletter, that's our primary contact database. Please do that. And one more thing, and you'll see these slides in the presentation also for reference. And I'm sure, as you know, the schedule in our registration website is getting more and more up to date. And now you'll see each time we finish a presentation like this one, the link to the next presentation will open. So look forward to that. And with that, I'm going to stop sharing my screen, at least. And I'm going to pass you on to Dawn, who is going to introduce Dr. Lawson. Thank you, Dawn.
Thanks, Jerry. Hi, everybody. Thanks for spending some of your afternoon/evening with us. We had a great lecture last week or 2 weeks ago, and I'm really excited about our lecture today. I'm going to introduce Dr. Lawson to us all, but I'd also like to ask you, as we go through the presentation, if you can put your questions into the chat. What I can do for Dr. Lawson is organize the questions and then read them off to her. And that way we can kind of, move through in a way that'll make it really easy for her to answer as many questions as possible, because I know you're going to have a lot because it's going to be a great presentation. So now I'm going to introduce Dr. Lawson to you. Dr. Lawson is a neurologist. She's an associate professor at the Geisel School of Medicine at Dartmouth. She used to be over in Ohio State University, but she's moved over into New Hampshire now. She's worked at Dartmouth since 2015, and she has a particular interest in genetic forms of neuromuscular disease and neuropathies. So you can see how that would lead her directly into Fabry disease. And her work on small fiber disease, as what we see in Fabry disease, has led her to be very involved in the community, both at Ohio State and now at Dartmouth. She also heads up the Muscular Dystrophy Association clinic out at Dartmouth. So it's a great honor to introduce you, Dr. Lawson, and I am excited to hear your talk tonight.
Thanks so much, Dawn. Well, it's exciting to be introduced by you because you are such an important person in the Fabry community and in the literature. So it's great, and it's great to see you again. All right, so I am going to try to share my screen, and hopefully this will work because I am not technologically literate.
Can you see them?
Mm-hmm.
All
Got
right.
it. Looks great.
Dr. Lawson, I'm going to be your slide changer. And if you would like to
Excellent.
start whenever you're ready.
Excellent. Well, first off, sorry everybody for the delay. That was a great example of how good I am about technical factors, technical difficulties. So I apologize. So yeah, we're talking a little bit about pain, and Jerry, you can go ahead and advance for me.
Let me see if I can advance from here, or if I have to open you up in a program. It says open with, and
I'm going upstairs.
What?
I'm going upstairs.
Okay.
maybe Google Slides. Let me try that.
Yeah, it's not letting me advance.
Oh, this has been like 45 minutes
Of what?
trying to troubleshoot. Get her
Okay,
slide.
I can advance them from this view. Let me try it in. So I can advance them from this view. So if you tell me, so I'm going to the second slide, your disclosures, can you see that?
Yep. Yeah,
Okay.
and that's just a quick disclosure slide. You can keep going.
Okay.
All right.
This contains notes also. But
Yeah, and just if you want, if you can go to the previous slide, and if you can go to the screen view, that's great. The presentation view.
I'm in Google
Yeah,
Slides.
up at the top right corner, it says present.
While you're working on that, I'll just keep
Okay, I
talking.
think I'm there.
So perfect. So I took this quote from a book by Bill Bryson, who has written something called The Body, A Guide for Occupants. And he has a little chapter in there about pain that I thought was a really sort of salient description of pain. He starts by calling it a strange and troublesome thing. And if we think about pain, the sort of the biologic function of pain is really to, after all, give us a warning signal when there's injury to tissue. And that is, he goes on to sort of describe this as, so sensitive are we to threatening stimuli that our bodies are programmed to react and withdraw from painful events even before our brains have received the news, which really reflects sort of the biologic sort of importance of pain and how complex a phenomenon it is. Clearly it's important, and clearly it's got a lot of mechanisms sort of behind it that make it a very complex entity. And you can go ahead and advance, Jerry. And as he's working on this is a pain we think of this as a phenomenon of the brain, but interestingly, the brain has no pain receptors, has no pain center, unlike a lot of our neurologic function. Then we think of it as a phenomenon of nerve, which certainly makes more sense, and particularly in the setting of what we're talking about today. But there are aspects of that that don't make sense either. For instance, phantom limb pain, when you lose a limb, and yet the body still registers that injury is happening. And are you able to advance, Jerry?
Is what you're seeing what you should be seeing, or is
I
is
still
going to
see the
close that white
previous
space?
slide.
Is this the right one?
Nope, it's not changing.
It says slide 6 where I'm at. I can go back.
If you take your cursor down to the very bottom,
Right.
it should have a little pop-up, and you should have like a little play button that you can proceed to the next one.
This is what all I'm seeing is what the previous and next. What you're seeing, I think. I'm not sure what will happen if I minimize the right. So which slide should I be on?
Reading.
I can go previous types of pain. You haven't done that. This is what you were on. So you want this one, right?
The next one,
The next
if
one.
you can.
Objectives.
No, it's not showing up on the screen.
I only see, previous and next. I guess it's previous, next, and current. Sorry, I'm trying to figure out what it wants me to do. So which actual slide number is it, Dr. Lawson, that I should be
It
in?
should be slide 4, Jerry.
Oh, okay, so. All right, is that it?
No, it's not advancing. It might be a different window we're looking at. Maybe take it out of a screen show and we can just kind of go through it on a smaller scale.
Yeah, this is called slide 4 on my screen.
Yeah, try escaping out of that and see what happens.
Nothing.
Nothing. All right.
What
I'm
about
still
There we go.
viewing.
Types of pain.
There you go. There you go. Perfect.
All right.
Okay.
Good job.
That's what we're looking
Good.
for?
Yep. That's the next slide. So when we're talking about pain, this is just sort of the language of pain. We talk about different forms of pain. Nociceptive pain is the type of pain that occurs when you hurt yourself, when you stub your toe, when you break a bone. It's often referred to as stimulated pain. It's what we think of as probably the most biologically functional pain, that is protective pain. It's what tells us that we've hurt ourselves. if you've ever twisted an ankle or hurt a knee, then you've had inflammation, where you get hot, swollen, red joints after a tissue injury. That's another type of pain that's also sort of thought of as sort of a reactive pain that occurs because of sort of influx of inflammatory cells and chemicals that have as one of their effects pain. Dysfunctional pain is pain that occurs when there's no stimulus for it. There seems to be no reason for it. And it's one of the things that we really struggle with. An example of dysfunctional pain is fibromyalgia. But there are other types of dysfunctional pain, like interstitial cystitis and irritable bowel syndrome. Migraine headaches can be part of dysfunctional pain. And this all has sort of mixes up with probably nerve factors, but potentially also brain factors, which is probably one of our most difficult to understand forms of pain. And then we come to neuropathic pain, which is important tonight. Neuropathic pain occurs when nerves outside the spinal cord and brain become damaged or sensitized. This can often evolve into chronic pain. It's thought to be entirely a nerve-generated phenomenon. And Jerry, if you could go forward. Hopefully.
Whoops, sorry, did I go one too far?
No, there we go. Oh, one too far. Yeah, one back. One forward. One back.
Whoop, I think it's just taking a second to catch up. And
okay.
Is this the right one?
That should be the right one.
Okay.
So essentially one of the things I wanted to sort of highlight tonight, so there's a lot of data that is out there from clinicians, from physicians, from scientists, from people who work in healthcare. But I really like this study, which came out relatively recently back in 2019, before the pandemic hit. And actually, Jerry is one of the co-authors on it. And I like this study because this is a survey-based study of over 350 patients that have Fabry, and sort of talk about some of the pain experiences they have. Interestingly, and I've included one of the key tables in that study, but I'm going to touch upon it as we go through. Almost 80% of patients with Fabry disease report having moderate to severe pain, and over 50% report that being frequent. So that's a pretty impressive, those are impressive numbers when you look at that. So certainly we know that Fabry is painful, but that's a lot of impact on quality of life. And go forward, Jerry, if you can.
Okay.
There's different types, of course. You all are aware of that. And click forward again, Jerry.
Okay.
There's the chronic form, and click forward again, which is predominantly in the hands and feet. It's characterized, and continue to click for me, characterized by this very typical description, this burning, tingling, stabbing, shooting, which is a pretty specific description for involvement of certain types of nerve fibers, which we'll kind of touch on as we go forward. So we knew certainly that hands and feet, the farthest away parts of our body are more at risk for having this pain, both constant as well as sort of episodic pain. But interestingly, looking at that survey study again, sort of underscoring what we kind of knew, but I think this really highlights it, that almost 85% of individuals with Fabry are experiencing pain in their hands and feet. And almost 2/3 of those individuals are also having abdominal pain. Another important part of Fabry that is really tough to manage. And keep going, Jerry. The abdominal pain can be associated with other abdominal symptoms that I'll touch on. But one of the hallmarks of Fabry that we talk about with other physicians is that this pain can hit in areas that are a little bit odd, that is joints, shoulders, even teeth, and is sort of one of the hallmarks of the disease. While it's chronic, there is also these sort of acute, superimposed, kind of episodic flares of pain that can be triggered by specific things, including fever, stress, hot weather, physical exertion, which I'm going to come back to. And keep going, Jerry. Click
Okay.
forward for me.
And again, or no? No.
Yeah, perfect. So the different types of these pains have sort of been outlined as sort of referring to different, quotes, phenotypes, which are different forms of the pain. We talked about the hands and feet pain. We talked about acute sort of pain flares. They're also referred to as pain crises, where the whole body gets involved in these sort of excruciating sort of attacks, often triggered by kind of heat stimuli. There's also this phenomenon that we call allodynia, where stimuli that should not be painful becomes painful. That can be a touch, a temperature that shouldn't be uncomfortable, and it's related, it's cousin or of hyperalgesia, where an uncomfortable stimulus becomes much more uncomfortable. This is when you get pricked by a pin, but it really is terribly painful, just more than would be expected. Also sort of a characteristic of Fabry disease pain. The abdominal pain in 1/3 of patients comes along with diarrhea, whereas 3/4 have just plain pain. And you can go forward. So there's some features that I wanted to sort of highlight that came out of the survey study that are sort of interesting. One is gender differences. And when we look back at the literature, a lot of the literature seems to suggest that, as expected, males are more affected than females. But that's not what the survey data shows. In fact, the proportions of males and females that experience moderate to severe pain are equal. Not surprisingly, the survey kind of corroborated what the literature suggests, that as individuals with Fabry get older, there are fewer individuals reporting the more severe pain, and fewer individuals experiencing hand and foot pain. Typical GI manifestations, bloating, diarrhea, early satiety. This is in both males and females, but females tend to get more constipation as well. And a piece of data that really kind of caught my attention was relating to enzyme replacement therapy. So the survey data showed similar rates of pain experienced in individuals who were receiving enzyme replacement therapy and those who weren't. And if you could click forward, Jerry.
No, so they can hear everything you're saying.
And that's not quite what we expect from the literature, both from a large enzyme replacement therapy clinical trial that Dr. Schiffman head up, showing that using one of the pain scales, it seemed that enzyme replacement decreased neuropathic pain, as did the Fabry outcome survey, suggesting that alpha-galactosidase A was effective at reducing the severity of pain. That's not entirely consistent with all the literature. Another European study suggested the same thing that the survey data suggested, that is that enzyme replacement really had no effect on pain. Go ahead and go forward,
Okay.
Jerry.
Yes.
So in order to sort of understand some of these, we got to go back to some basic principles of sort of biology. So when we think of a peripheral nerve, that is the nerve outside of the brain and spinal cord, we think of something that looks like this. This is a motor neuron, or a nerve cell. The cell body that we see here is sitting in the spinal cord. This long process that goes out from the cell body extends out, if it's in the neck, out in the shoulder, if it's down in the low back, out into the hip, down to our muscles. These are big nerve cells that have this big fatty lining called myelin around them. The signal travels very fast and very effectively. And go ahead, Sherry.
Okay.
So while the motor nerve cell is taking signals from the spinal cord out to the muscle to allow us to move, the sensory nerves are doing the opposite. They're taking signals from the skin back up to the spinal cord to take it up to the brain. And this cartoon I like because it shows a lot of important features that have relevance to Fabry. So you see the spinal cord on the left there. The two bulbous structures kind of in the middle are the cell bodies of these sensory neurons. So instead of cell bodies in the spinal cord like the motor nerves, these sit beside the spinal cord and they're called the dorsal root ganglion. And there's two fibers there. One is called a C fiber and one is called an A delta fiber. And these are going to be important as we go along. But you can see the C fiber doesn't have that fatty lining to it, and the A delta fiber does, but it's kind of thin. It's not the same kind of lining that we expect from the motor nerves. So these cells, or these nerve cells, are a little bit slower to get information from the skin up to the spinal cord. And you can click forward, Jerry.
Okay.
And this is sort of a depiction of why that becomes important. So on the left, we see what I refer to as the Ferraris of the peripheral nervous system. The nerves that carry the signal from the motor, from the spinal cord to the muscles to cause the motor movements, and big sensory nerves. That is, the nerves that carry signals that tell us about touch, about where our limbs are in space, help us to stay balanced. They're also the ones that you notice when your foot goes to sleep or you cross your legs and you don't know where your foot is in space. Those are the big, very fast firing nerves. The ones I want you to really pay attention to are the ones on the right side of the red line. Those are the nerves we call small fibers. And you can see there's small fibers somatic. Somatic refers to nerves that pick up sensation. and autonomic. Those are the nerves that are responsible for what I think of as the sort of heat and lights in the nervous system. Your blood pressure, your heart rate, your sweating, your gut function, your abdominal function, those kinds of things. These are small, they're slower, they don't have as much of that myelin or that fatty lining around them. And if you pay attention to the somatic part, they're responsible for a different type of sensation. That is pain, obviously that's important, as well as temperature. The C fibers pick up heat and the A delta fibers pick up cold. You can go ahead, Jerry.
Okay.
So how does that translate into what we see or what people experience when these different fibers are not functioning well? So this is from a big Italian study looking at not Fabry's disease, but a lot of patients that have similar type of injury, these small nerve fibers being injured. And the VAS that you see up in the right-hand upper corner of this graph, it stands for visual analog scale. So this is how much pain people were experiencing. A larger number that is greater than 4 means they were experiencing more intense pain. The smaller number, less than 4, is less intense pain. And what you can see is clearly the individuals with the small fiber neuropathy experienced more pain than any other type of neuropathy and any other kind of neurologic disorder or musculoskeletal disorder, like a tendonitis or a bursitis or a broken bone or anything like that. So it helps us to understand these small nerve fibers clearly have an important role in the in pain and in sort of related sensations. And you can go ahead, Jerry.
Okay.
The character is pretty typical as well. So those individuals with the small fibers that were affected tended more than the others to have this burning sharp sort of sunburn kind of pain. They also described a kind of deep aching pain, which led to, there's a sort of a movement afoot that a lot of individuals with fibromyalgia may actually have this small fiber neuropathy. On the other side of the coin, people who have small fiber neuropathy may have fibromyalgia-like symptoms as part of their sort of pain picture or pain spectrum. And you can go ahead, Jerry.
Okay. Whoops, did it go too far?
No, you were great. Go back to.
It's moving and I'm not touching anything.
So I'll start talking as Jerry goes back a little bit.
I have to wait for it to stop moving by itself here. Oh, I see.
So essentially, when we're trying to kind of get our head around these different types of neuropathies and figure out whether a small fiber neuropathy exists, one of the things we reach out for is this test, is the skin biopsy test. And that's because most of the small fibers live in the intraepidermal space. That is, they go up to the skin where most of our sensing goes on, and that's where we see the highest density. And you can go forward one.
Okay.
So when we're looking for these small fiber neuropathies, we take a sample of skin, and you can see in the upper diagrams what we see in the setting of a normal skin biopsy and a skin biopsy from somebody who has a small fiber neuropathy. On the left, we see these little fibers that are permeating through the skin. On the right, we don't see any of them. And this is a better test for these small fiber neuropathies than even taking a sample of a nerve. And you can go forward.
Yes.
So this has been done in patients with Fabry disease. And if you look at these two graphs, we have a set of numbers for male Fabry patients and a set of numbers for female Fabry patients. The light blue bars represent the numbers that we expect, the normal numbers, and the dots represent the numbers we get that were obtained from patients. So you can see on the left, in the male patients, just about every individual that was tested had low counts or low densities of these nerve fibers in the skin. A little over half of women with Fabry disease also had that. And you can go forward.
Yes.
So that doesn't quite fit with this idea that came from especially the survey data that showed that women and men seem to have the same amount and the same severity of pain, sort of regardless. How does that sort of make sense? Well, if we again go back to the literature on other types of small fiber neuropathies, and this again comes from this big Italian study, not on Fabry disease patients, but on a lot of different patients having this small fiber neuropathy from different causes. On the left, we see the density. As you go up, that means the density is higher. And on the x-axis is the visual analog scale. So again, the higher number means more pain. So if fewer nerve fibers in the skin meant more pain, this line should be headed the other direction. It's going the wrong direction. So it almost looks like, so certainly what this tells us is that pain is not the same as number of these small nerve fibers. And in fact, it may be that as you get fewer of these nerve fibers, you get less pain. And you can go forward.
All right.
And indeed, that's exactly what we see in the Fabry literature. So this diagram shows on the left, you can see at the bottom is normal sensation. As you move up the left side of the graph, there's a worsening of the function, of the sensory function. So the top is where you've really lost sensation in various places. As you look at the x-axis, that's advancing age and advancing disease severity. And on the other side, on the right-hand side of the graph is, as you go up, is increasing pain severity. The green line depicts the progression of the disease with time and worsening sensation in the hands and the feet. But pain, while it gets worse in the early part of the disease, then tapers off, and it gets less as age advances. Again, consistent with what the survey data suggested. So interestingly, and this is the same thing in both men and women, just a little bit more delayed in women compared to men in terms of when this sort of curve starts. So interestingly, apparently with increased age and more severe disease, the nerve fibers stop working well, or that's the implication, and they no longer result in pain. And you can keep going, Jerry.
Okay.
So that kind of goes along with what we know about Fabry's disease. So Fabry's disease, neuropathic pain, behaves as we would expect it to in the setting of losing these smaller nerve fibers, the A, delta, and C fibers. Those are exactly the fibers that are lost in Fabry's disease. Those are the fibers that are responsible for pain, especially and temperature, especially warm and cold sensations. And it goes along with where we see these deposits ending up in nerve. That is, they get deposited in this dorsal root ganglion, in the cell body of these sensory nerves, and they seem to affect predominantly these A, delta, and C fibers. So that all kind of makes sense. Certainly the Fabry's disease pain behaves as we would expect for small fiber neuropathy. It shows the same character, and it shows sort of the same natural history. But then we have these other sort of pain things that happen, like spontaneous pain or evoked pain. These pain crises, which are a little bit less clear. Where this is coming from is a little less clear. And you can go ahead, Jerry. And we think that this may have something to do with how these nerves are reacting to injury. So we know that nerves have a certain sort of frequency of firing. That is that an electrical signal passes down in the case of a motor nerve or up in the case of a sensory nerve. And that's mediated through some kind of electrical response of the nerve. So what is that? How does that happen? Well, if we look at the sort of biologic sort of translation of that passing of the signal, we see this happens because of these channels that sit in the membrane of the cell and allow certain salts or ions to pass through the membrane. And that translates into an electrical signal. These channels are most often, can be other, even potassium, but sodium seems to be one of the most important ones having to do with these small nerve fibers, small fibers. And in fact, a study that was published sort of early in the last decade showed that when you take small fiber neuropathies that you don't have a good explanation for, it seems that a proportion of them have a genetic change in these specific channels. So these channels seem to have an important role in not only the function of the nerve, but also in mediating some of this pain behavior of the nerve. You can go ahead, Jerry.
Okay.
So, and we see these are also called SCN, that's the name of the gene for sodium channel nerve. And we see that a lot of these other neuropathies have been linked to different mutations in these sodium channels. And interestingly, when you look at those nerves, the effect of those gene mutations, it appears to make these nerve cells more excitable. That is, they fire more than they should. and keep going. And interestingly, when that happens, we see that correlating with a lot of the symptoms that we see in these small fiber neuropathies. That is this typical neuropathic pain, especially in the feet, that it can manifest in sort of odd distributions, places we wouldn't expect it to be. That in some patients, it shows up as muscle pain, like a fibromyalgia or aching pain. And that it can involve also some dysfunction of the heat and light nerves that I mentioned before, the autonomic nerves. So it seems that these sodium channels may be important in sort of propagating that painful stimulus, no matter what is going on. And you can go ahead.
Okay.
So not only does the channel itself seem to be important, and if you'll click one more time, Jerry,
Okay.
but there are other proteins that kind of that influence how these channels work that also seem to be important and may be very important sort of regulators of the protein. The one that I'm pointing to here, ankyrin, is going to be important in a moment. And keep going. So a group of scientists looked at how rats that had they developed a rat model of Fabry disease, and looked at how they sort of responded, and how neuropathic pain was generated in these rats. The first thing they were able to demonstrate is that this model behaved the way they would expect it to, in sort of mimicking the human disease. That is GL3 deposits, the metabolite from Fabry disease was deposited in that dorsal root ganglion, in the cell bodies of those sensory nerves, as would be expected. It also appeared that the most affected nerves were indeed those small nerve fibers, the A, gamma, and C fibers, again consistently. And interestingly, they were able to pick up that the ion currents were abnormal. They were sensitized, meaning there was more firing in nerves than there should have been. And they were able to determine that this was located, or this was a result of the channel that was under the control of this ankyrin protein, or the transient receptor potential ankyrin 1. So this is essentially the channel that is controlled by that protein. So this channel that affects how that sodium channel opens and closes, and therefore affects how currents go back and forth across the nerve cell membrane and how much the nerve was firing, was a very important part of the rat's behavior in terms of pain.
Interesting.
And you can go ahead. So it appears that this TRPA channel also gets sensitized, not only in this rat model, but in other situations in the setting of inflammation, nerve injury, diabetes. When these authors blocked that channel, the currents became less sensitized and the pain started to exhibit less pain behavior. So this sounds to be a pretty important part of this whole pain story. And you can go ahead. So with that in mind, we come back to what is really the bottom line when it comes to pain? Well, the bottom line is, how do we make it go away? How do we control it? How do we get that number of 80 to 85% of Fabry patients dealing with moderate to severe pain? Well, the first thing we do is we think about enzyme replacement therapy.
Okay.
Clearly, it's not performing as well as we'd like it to. Certainly, the survey data suggests that there is some conflicting data out there about what enzyme replacement therapy does for pain. But the fact that there's conflicting data suggests, at least to me, that there's work to be done. So we don't really know what the effect of enzyme replacement therapy is on pain. We can imagine that if those nerve cells are already sensitized, that even if we stop the deposition of the GL3, then we may not be doing very much to actually reverse the process that's producing the pain. So the question comes up, does timing matter? Is it important to start enzyme replacement therapy as soon as possible to prevent that GL3 from depositing in the dorsal root ganglion? We don't really have that answer. Does dose matter? Do we need to be using higher doses to really sort of empty those dorsal root ganglions of the GL3? And then, of course, one of the questions that we're going to hear more about, I'm sure, is what's the impact of some of the newer agents that are coming out. Certainly, there's an effect of enzyme replacement on other organ systems that may then have downstream sort of protective effects on nerves. That is, if you develop kidney disorder, then you can have what's called uremic neuropathy, where the high levels of uremia that happen because of the renal dysfunction affect nerve. So it's a secondary nerve injury that has nothing to do with the GL3 deposition in the dorsal root ganglion, but still has an impact on nerve. If there's a cardiac effect and that prevents you from being able to, stay healthy and remain active and get some cardio involved, then you may have difficulties with your sugar going up, especially in the setting of weight gain, which also has an effect on nerve. So it may be that enzyme replacement actually has some of its effects by protecting the nerve from the downstream effects of other tissues being injured. And you can go ahead, Jerry. But we also have to talk about symptomatic therapies and how we manage pain day to day. Some of these are very, straightforward, common sense kinds of things: avoiding triggers, cognitive behavioral therapies, physical therapies. But then the others have to do with what can we use to relieve pain. Before I start talking about that, I do want to take a step back on triggers, because interestingly, the things that are triggering, that are believed to really trigger these pain attacks, have to do with heat, fevers, physical exertion where your body temperature goes up, exposure to heated environments. Those are exactly the stimuli that sort of get these C fibers going. And it may very well be that the heat sort of has this effect because it contributes to the sensitization of those C fibers. So avoiding those triggers is obviously important. But what are we thinking about when we're thinking about pharmacologic pain relievers? Well, we're thinking about anti-inflammatories, the non-steroidal agents like the ibuprofen and naproxen and meloxicam, all of those sorts of fibers. Plain old analgesics, these include tramadol as well as the opiate agents. Neuropathic agents, which are the ones that we reach for the most, which include some of the anticonvulsant class medications, antidepressant class medications, as well as topical agents. And then one that is really used very infrequently, IV lidocaine. And you can go ahead, Jared. So the ones we choose are probably guided in the general sort of neurologic community, most by this pretty comprehensive treatment of neuropathic pain by the European Federation of Neurologic Sciences, where they really looked at a lot of different agents and looked mostly in these three models: diabetes, post-herpetic neuralgia or after shingles, and trigeminal neuralgia. And if you'll go forward once, Jerry.
Okay.
And I want to sort of direct your attention to the level A, one back, if you will.
One back, sorry.
Yeah. The level A rating, meaning the evidence was strongest for the use of some of these agents. Duloxetine or Cymbalta is an antidepressant agent. Gabapentin is an anticonvulsant. The tricyclic antidepressants are, again, antidepressant agents. And then pregabalin or Lyrica, which is an anticonvulsant agent. And then in trigeminal neuralgia, I'll sort of direct your attention to another anticonvulsant agent that's been used in Fabry disease, carbamazepine. Unfortunately, carbamazepine doesn't seem to have much data to support its use in some of these others, like the diabetic neuropathy. You'll see it's only got a level C rating for effectiveness for diabetic neuropathy. So jury is a little bit out on that agent. And if you'll go forward one.
Okay.
And then more recently, this is another sort of large sort of meta-analysis where a group of experts got together and looked at all the data that supported different agents and their use for neuropathic pain. And it looks like the strongest data supports gabapentin, Lyrica, and then these what's called the SNRIs, so serotonin and norepinephrine reuptake inhibitors, which are antidepressant agents, duloxetine or Cymbalta and venlafaxine or Effexor, as well as the tricyclic agents. And then sort of had weak evidence for some of the other analgesics, especially tramadol and opiates. Obviously, some big problems with those, as we're all aware of. And you can go forward, Jerry.
Okay.
So those are sort of old therapies. They've been around. We have kind of different data that supports the use of what I think of as the sort of the big three, the gabapentin, Lyrica, Cymbalta, possibly with the tricyclics, although in Fabry disease, there's some concern about that with cardiac manifestations. But then sort of thinking ahead, I think especially with some of this data that's coming up on the TRPA1 channel, there are medications that are not yet out on the market, but are probably coming, in the migraine world, that antagonize this channel. So maybe something that will be of use in the neuropathic pain world as well. And then thinking about what we're using based on what we think is going on. And that has to do with, considering what exactly is happening with pain. What is the biggest type of pain, whether it's abdominal pain, whether it's continuous pain, whether it's pain attacks, whether it's sort of sensitization of the skin to non-painful stimulation. and trying to use some of these different agents to really tailor a pain regimen to each person. Now, whether that works or not is it's not clear yet. And you can go ahead. So just sort of summarizing what we talked about today. So we talked about pain and how that interacts with sort of the structure of nerve and sort of a more in-depth understanding of peripheral nerve and how specific fiber type involvement can really dictate what happens and how pain sort of shows itself. How dysfunction of that nerve can translate into the experience of pain, and hopefully management opportunities that are coming up in the next decade. So certainly drawing from pharmacologic evidence that that comes from other types of neuropathies and other types of pain disorders. Whether these are transferable to the Fabry population is yet to be seen, but I think this is probably the future of the pain world in Fabry's. And with that, I'll sort of wrap up, and we'll be happy to take any questions. And again, I apologize for all the technical difficulties.
Well, thank you, Dr. Lawson. That was great.
Yeah, thank you so much. I appreciate your perseverance and keep going and seeing what we could do to make it work. So I do have about 3 questions, so I'll start with those, and then you guys, as you have other questions, go ahead and bring them on. The first question was, is there a mechanism for prednisone to help with pain? Not necessarily bone pain, but other pain.
A wonderful, wonderful question. Yeah, I mean, we talked a little bit about this concept of inflammation pain, and we know that if you've ever hurt your back or twisted your ankle and you have a lot of swelling and redness, then many times your doctor will give you a short course of prednisone. So yeah. Prednisone seems to have a role in inflammation pain. Is that a significant part of Fabry disease pain? It's not clear. There certainly was some question that there may be inflammation as part of the pain kind of spectrum, but it doesn't seem that Fabry's patients respond well to prednisone. They don't seem to improve much in terms of pain, and it may be because it's just such a complex sort of amalgam of different factors. I can see, though, at some point when we start to find the right types of agents to treat, especially these sort of extra sensitized nerves, or these hyperexcitable nerves, that prednisone may be a part of that, but only a part. I think its role by itself is probably limited.
Thank you. There's a question here about migraines. So you'd mentioned that migraines, that they're trying new medication for migraines, and migraines have been part of Fabry disease, but not really listed. And they're just wondering, can you tell us a little bit more about migraines and Fabry disease and how they might go together?
Yeah, well, certainly there's another concept that I didn't talk about because it's a big topic that has to do with central sensitization. So we know that pain has different locations. We talked mostly about its location in nerves and the role of sensory nerves in producing pain. But there's also probably what we call pain generators that sit in the spinal cord, as well as a response of the brain to pain. And, a lot of the fibromyalgia literature, for instance, talks about this central sensitization, where the brain seems to reprogram itself to kind of produce more pain or allow for the production of more pain. Migraine may very well be part of that, but exactly how that happens is not well understood at all.
Next question. Why are there random crises that are not brought on with a trigger? So I think pain crisis is what they're asking about.
Yeah, excellent question. Yeah, I suspect that there are other factors, chemical factors, metabolic factors, hormonal factors that also impact how sensitized the nerves are. It certainly makes sense that thermal triggers, so heat triggers would impact how those C fibers are acting. But I would also expect that cold triggers would do it, and I don't think that's quite as universal. So I suspect there's a lot of factors that we just don't know about, that we haven't gotten far enough to understand those yet.
Thanks. Here's a question. I have been told to reduce my sodium intake. Will that reduce those information highways you spoke of?
Oh, I wish. Unfortunately, no, because it's not the sodium content that is the problem. It's the way the nerve is handling the sodium, the way it's moving it back and forth and translating that into a signal that goes up and down the nerve. So it's not, it would be great if we could adjust those salt concentrations and make things better. But there's too much processing that goes on before it actually gets to the nerve that it would impact that.